Today, we have the great pleasure of listening to Dr. Pam Hinds. And Dr. Hinds is the interim director of the Center for Translational Research and the director of the Department of Nursing Science, Professional Practice and Quality. She's also the research integrity officer at Children's National System and a professor of pediatrics at the George Washington University. For more than 3 decades, she's created and led research in pediatric cancer experience, and she's an expert in patient-reported outcomes. She actually served on the initial Institute of Medicine Committee on End of Life for Palliative Care for Children in America, so back in 2003. This is a book that most of kind of the next generation of pediatric palliative care providers has not actually seen that book. And yet that book was the most referenced thing when we were getting started in pediatric palliative care here in the US. And on the National Academy of Sciences and Engineering and Medicine Roundtable on Quality Care for People with Serious Illness. She was a part of the NCI Moonshot initiative, and she represents patient-reported outcomes on 2 different treatment protocols for the Children's Oncology Group. On a very personal note, Pam is my mentor, and so that is a disclaimer I need to say. Pam is much more than a mentor, though. Pam is a part of my family, and Pam has made that very clear. That is not from my perspective, that is from her perspective. And I can't tell you the love that I have felt across the years in this mentorship role with her. There's nobody that is better at cheering people on than Pam Hinds. And for those of us in academic medicine, you need a cheerleader. You need somebody who's constantly pulling for you. And that person for me across the entirety of my career has been Pam Hinds. And any moment that I wonder what I should do, that I think about what is the right decision to make, I think, what would it be that Pam would recommend for me to do? And that's gotten me, to do just fine, because Pam is such a special person. And so I'm so grateful to come and to get to introduce Pam and to have her come and speak to us. She'll actually be talking to us about something that she has led dozens of studies about, had major funding at the NIH level and multi-institutional funding on being a good parent to an ill child. So Pam, it is such a pleasure to introduce you as our keynote speaker, our grand round speaker, and our inaugural speaker for the Innovations of Pediatric Palliative Care Conference. So come on up.
Good morning to every one of you. I am incredibly happy to be with you. I want to thank you for having me. You have very special ties to the topic today, and I'm most grateful for that. Do you know that Mike Link was one of the editors for the Journal of Clinical Oncology when we published our first Being a Good Parent to My Very Ill Child? And he said to me, I don't think you understand. You've just broken the qualitative research glass ceiling for this journal. And Sherry Spunt, expert pediatric oncologist, who was inspirational as a collaborator for this science. Dr. Justin Baker, who has been a collaborator and always has had the courage to ask, why? What next? I'm very grateful for what you have given to pediatric palliative care across our nation and across borders. I look at the work that Dr. Barbara Swartz has led here, the founding of your service, the wonderfully positive handoff to Dr. Baker and team. It's a credit to every one of you. So thank you for bringing me here, and I thank you for this chance to acknowledge all that you have done. But I do bring you very friendly greetings from Children's National Hospital. And this is the only freestanding pediatric facility in the District of Columbia. We're a little bit over 330 beds, most of which are critical care. And I suspect ultimately it'll be completely critical care beds. We have primary care clinics and we have specialty care clinics in Southern Maryland and Northern Virginia. So it's a really neat opportunity to reach across state lines and to learn about the implications of that for palliative care. If I may then first tell you that I actually have nothing to confess, no relationships that I need to alert you to, but oh my gosh, do I have appreciation for all the funding for the research that I'm about to share with you. I'm very grateful for the federal government and for foundations that are willing to tolerate this label, being a good parent to my very ill child. We'll say more in a few moments about how troubling that label, though it comes from parents, has been for the federal government. I thought during our time together today, we might talk historically about the evolution of this concept of being a good parent to my seriously ill child. From whence did it come? Where is it now? And very concerningly, what's missing? What are the gaps in our science? What can we do to take this concept and make it much more valuable for clinical practice? So today, during our time together, I'm going to try to synthesize for you about 60 different studies about this concept of being a good parent to my very ill child. I'm going to offer some facts and some interpretations, and I look forward to your thoughts as well. So let's begin with a little bit of a dialogue, and I'm going to invite you to share out loud when you hear the words, being a good parent. What word or words come immediately to your mind when you hear the phrase, being a good parent? What do you think of? Love. Good. What else? Support. Sorry, I think someone said something and I missed it. Can you hear it? Courage. Oh, courage. Yes. What else? Sacrifice, for sure. For sure. Advocacy. Oh, yes. Oh, yes. Compromise. Being there. Compromise. Courage. Fear of regret. All right. So you hear those words. We are all nodding. We understand and respect these words. Now let's also say out loud, what do you think of when you hear the words, being a good parent to my seriously ill child? What words would you now say out loud that this phrase reminds you of? Heartbreak. Advocate. Protector. Compassion. Love. Similarities between being a good parent and being a good parent to a very ill child. So there's overlap, isn't there? And there may be nuance of differences too, but the words have meaning. They have meaning for us already as we interact with families, as they do for families who are interacting with us and with situations about their child's health. So why would you and I worry about words? Why would we spend these moments asking each other about the meaning and the value of words of being a good parent? And we do, because more than 110 studies tell us that by parent report, our words, how we phrase them, the intonation we give to them, can help them or interfere with them from achieving what they believe to be the definition of being a good parent. And according to these parents, our use of words and our interactions with them and our intonation might protect them from psychosocial risks. Doesn't prevent the risk. The risk is there, but it might reduce some of the risk, or it might help parents to make sense of a high risk situation. So according to parents, our words matter. So may I take you to the beginning, when we decided as pediatric oncology protocol-driven people that we wanted to look at how we did end-of-life decision-making and conversations with families. Please keep in mind that we were so used to having protocols that told us exactly what drug to administer, in what dose, how to titrate, the timing, the mode of administration, everything was spelled out for us. Parents were really not involved in decision making from anywhere from 9 months to 3.5 years because the protocol made the decisions. Until the biggest decisions of their life would suddenly come into play when the child's cancer became incurable. And then suddenly we were asking them to become involved in deciding about resuscitation, use of experimental drugs, going home on home hospice or staying with us for hospital hospice. And we looked at each other as team members and we said, we're not good at this. And parents gave us feedback that said, you're really not good at this. So we knew we needed to look at ourselves, and thus began a series of descriptive studies about treatment decision-making, particularly at end of life. And we learned from families across these studies, 2 international studies, that there are 9 factors that they considered when they were trying to help with making an end-of-life decision. Now, I'm going to suggest to you that all of those factors in black font, I bet you know immediately from your own practice what they mean. For example, nothing more to do. We've done everything. And I really trust when the staff says to me, we've done everything. You've done everything. Or not wanting anything negative to happen anymore. Very self-explanatory. All 8 of those in the black font, I know you would be able to define. But I can tell you, as a study team of clinical investigators from all different disciplines, we looked at that phrase in red font and we looked at each other and said, what does that mean? What does it mean that you would decide as a good parent would? And quite honestly, we did not have the data to help us know what this meant, but we knew it was important. With every one of our descriptive studies, 80% of our parents identified this as the most important factor for them. Other factors were certainly important, but they were not identified by 80% of a sample across studies. I'm going to tell you my interpretation and my personal belief, and that is that the real value of pediatric palliative care is prevention. I believe that we have the final opportunity to prevent certain outcomes for families. We may be the last opportunity they have for protection. Now, we do have national statistics, not from our country, I'm sad to say, but from other Scandinavian countries primarily, China as well. And we do have regional and state and institutional statistics that tell us that when parents lose a child, they are at high risk for certain endpoints. This is not every parent, but statistically significantly speaking, moms are more likely to have a first hospitalization for psychiatric distress. Dads are more likely to leave employment. So a family that has a hole from losing a child now loses financial stability and loses emotional strength. And we also know that parents, statistically, who lose a child are likely to die younger than those who do not. Now, again, this is not every parent, but there is a statistically significant difference between those who do and those who do not lose a child or have a child with a complex medical condition that is enduring. So that took us back to the federal government to look for more funding so that we could learn what is the meaning of those words in the red font? What does it mean to be a good parent to my very ill child? And that began the next series of studies. And I would say to a parent to introduce the topic, may I share with you that parents have taught me that when their child is very ill, they are aware of an internal definition of what it means to them to be a good parent to this ill child at this time. Please, would you teach me your internal definition? Because I believe that if we know it here, we can help do our best to help you achieve or get as close as you can to your definition. And parents were generous in talking with us about their definition. So you'll notice that there are 7 major attributes that parents across our studies spoke of, and being adequately knowledgeable so that you could help to make a wise medical decision. To advocate for your child, even if it meant firing a physician, a nurse, or another team member who you have been close with for a long time, but you don't think they see you as a good parent who's trying to make good decisions. Or remaining by the child's side, even though it's incredibly difficult and the staff keeps saying, would you like to just step away? We'll stay right here so you can. Even if the child's on a ventilator, to still work to provide the basics: good food, good clothing, safety, protection. And to continue trying to teach the child the wisdom of life, how to convey respect, how to have sympathy for others in their life situations. And to believe that somewhere in the universe, there's a greater being, so that your child will know your child will never be alone. And most importantly, that the child will know that the child is extraordinarily well loved by the parent. Well, that's good that we discovered that in our studies, but better yet is when science is validated by others. And I'd like to take you into the world of Dr. Tessie October, pediatric intensive care physician, who did something way better than what I did. She interviewed parents of color. And most of the families in her study were Black, and they validated every attribute of the definition of being a good parent to my very ill child. That's important. Just as important is she discovered that when you have 2 parents, one parent will say, most important to me is that my child knows how loved he is by me. And the other parent will say, most important to me is that I am so well medically informed, I can help make good decisions. But if you are a single parent, and in this study, the single parents were moms, number one, most important was to make good medical decisions. So something does happen when you are alone versus when you have a mate. And then he went on and did a study with Chris Feudner, Doug Hill, enrolling 200 families from a palliative care service, not all children at end of life at that time. And I want to say to you that most of the participants were moms. 80% were moms and white. So please keep in mind where we're learning about this definition. And what these moms said was the most important for them was that the child know that the child is well loved. And then the next validation study took us right into the NICU, 40 moms, 26 of whom knew that ahead of time they were going to have a child with a very complex congenital anomaly that would threaten survival, 16 who did not know that until after birth. But their priorities, their description about being a good parent were very similar with one nuance. And important for us, these parents could hold at the very same time what might seem to be disparate beliefs, maintaining a positive outlook and being realistic. You know how we try so hard to make sure that parents know the facts, even getting forceful sometimes to make sure they're not going to be taken by surprise. Whereas parents across our studies have indicated they know what's going on, no surprises, but they choose when they wish to acknowledge it and when they choose not to have to acknowledge it. But what we learned in this study in the NICU, as we have learned in our other studies, is that even first-time parents of a child born with a very serious condition already have within them a definition of what it is to be a good parent. Now, we do have some international studies. I'd like to share one in particular from China and one from Brazil. China was able, in their study of about 40 parents, to validate all of the attributes except believing in a greater being. They added a new attribute that the parents in China said they had to learn, which was to change how they viewed themselves and now to become playful with their child. In Brazil, again, attributes confirm, but really important descriptors added. Being a good parent meant seeking information at all times, even if you had to go outside of your current team, not necessarily because you doubted the team, but because the job of a good parent is to have all information possible. To be strong, to be attentive, but that you cannot sacrifice family unity. You must be attentive to family unity. So nice validation, but with very important additions. So what we know then from our research is that many times there can be a thought about being a good parent, but when your child's health is under threat, and that's when all of you meet parents, that's when the good definition comes right to the front. It is front and foremost, and other decisions will be made based on that internal definition of being a good parent. Now, please, if you would, remember this ellipse because I'm going to suggest one of the gaps later is a missing ellipse. So now we have a definition, it's been validated, but could we learn something more if we look at the attributes? And I want to really credit Chris Feudner, who created a research tool in which he took all the attributes of being a good parent to a seriously ill child, and he added 2 attributes from his own practice. I'll share those with you in just a moment. And in this research tool, 4 attributes at a time are put together, and then you mix them up, and it's 4 additional attributes. And you ask parents to read the attributes and to say, which of these attributes is most important to you at this time? Second most important, third, and fourth. And what I do want to point out to you is here are rankings from Dr. October in the PICU. And what you can notice is that the top 4 most frequently reported, focusing on my child's health, putting my child's needs above my own, making informed medical decisions, making sure my child feels loved. Now, may I ask you to cast your eyes to the bottom? Notice keeping a positive outlook, keeping a realistic outlook are the lowest. Now, those did not come from parents. Those came from an expert palliative care physician clinician, Chris Feudner. Now let's look at how 200 parents rated most important attributes to them. Notice those top 4 look pretty similar to what came out of Dr. October's study. Cast your eyes again, please, on the bottom. Notice once again, keeping a realistic outlook and a positive outlook are not rated very high. Notice that in both instances, maintaining my child's spiritual well-being is very low rated. And parents explain that as, that's not anything that's going to change right now. We dealt with that a long time ago, so I'm not worried about that right now. Of course, then in science, we would say to each other, well, if you have an internal definition of being a good parent, is it static? Is it stable over time and situations? And what parents have taught us is not really. And so here I'm showing you data from 124 parents who we measured at baseline, 12 months later, and 24 months later. Notice that at baseline, pretty evenly divided between making sure my child feels loved and making well-informed medical decisions. But 12 months later, there's a dramatic shift in favor of making sure my child feels loved. 24 months from baseline, making sure my child feels loved maintains a dominance. Now, we could say to each other, maybe they had made all of their decisions to that point. Maybe they were in a stable period. I don't know. But it does suggest to me that clinically, We need then to know when a parent is likely to shift in either their definition or the attributes that are most important at this time. We believe that probably this is tied to the child's condition. And if the child's condition changes, then a team member close with the family may then, on behalf of the team, want to ask the good parent question. Which brings us to, should you and I intervene with this definition that is internal? Should we know about this and do something about it? We wondered the same thing, and so we did an intervention study. And what you will notice with 5 time points is that first we screened for eligibility. We went to the primary physician, then the psychosocial expert, and then the primary nurse to ask if this parent who had made an end-of-life decision might be eligible for the Good Parent Study. And then, if we got the go-ahead, we approached the family and asked if they would like to be in this study, explaining what it would be and offering them time to think about it. And then, when parents said they wanted to be in the study, we interviewed them for their definition of being a good parent. We got that information to the team members who were involved in direct care. And so within 24 to 48 hours, we got that information to 3 to 11 team members. And then we followed up 3 weeks after that. We asked the team to tell us what was helpful and what was not helpful. And then we followed up with parents to ask certain questions as well. So in almost 2 years, we had over 200 eligible end-of-life decisions. And gosh, did I learn about mistake making in this study. First, please, with a palliative care study, don't say that you're only going to interview face-to-face. What was I thinking? Over 90 families left almost immediately after making an end-of-life decision, wanting to get their child home. So clear mistake on my part. Notice too that I underestimated how many families our staff would say, please don't approach them. About half of the families that were eligible, we were told, please don't approach, this would be too hard. A proportion of families were Spanish speaking only. That's on me, that's not on them. That says everything about my limitations. But we did get permission to approach 58 families. We had slightly more than that, but we had an 18% refusal rate. And I'll tell you more about that. So this was a feasibility study for us. It's a big deal. We were scared. We were scared we would cause harm because we worried we were intervening with a situation that maybe had its own natural course. And what I want you to know is that we had hoped that we would have 60% yeses, and we had just over 82% yeses from parents wanting to be in the study. No parent withdrew. We actually estimated about 15% would withdraw. Didn't happen. We had parents tell us they liked being in the study, and 3 parents petitioned the IRB to allow them to be in the study more than once because they made more than one end-of-life decision. When we looked at clinician satisfaction, first of all, with being in the study and the documentation they usually have about end-of-life decisions, clinicians across teams indicated that they are sorely dissatisfied with how much documentation tends to be in an electronic health record about end-of-life decision-making. If you don't know what was said, what the options were, who was in the room, then a clinician is left with asking a parent. And a parent can misinterpret that as thinking this clinician is double thinking the mistake, that the decision they made might have been a mistake. So documentation about end-of-life decision-making is critically important. Here comes my second mistake. There were more, I'm sure. We asked clinicians, was any of this information valuable for you? And almost 90% said indeed it was. And then I asked, did this information in any way affect your practice? And clinicians said to me, why? Do you think I need to change my practice? We are very sensitive about end-of-life care. It's our last chance to do well by this family. And if we imply in any way that we don't think each other's doing a good job, that is particularly painful. So it's important for us to ask, who has actually been teaching us about this internal definition of being a good parent? And I would share with you this list. Groups of parents have been teaching us anywhere from 2 to 10 studies for every one of these groups. So this is good, but notice it's very limited. So that takes us back to then, if parents are telling us we have a role, how do they say we should help? And I do want to share with you this list from parents about how we can help them achieve their definition of being a good parent. You'll notice that one column is from parents who have a child with incurable cancer. The other column is from parents in the PICU. And I want to point out just a couple of these because they might not be self-explanatory. Many of these, like all that can be done has been done, I'm sure, would be self-explanatory. Notice the emphasis on wanting to be sure that the staff respected the parent decision, and that the parent would not be dismissed, that the parent as well as the child would be supported. There's something being deduced from this that's interpreted as we see the parent as having done their best. And so what we do then is interpreted in that manner. Notice this about, ask us about our faith. And families commonly say, I think you're very uncomfortable asking me if I have a faith. Just ask me. Or, couldn't you work better at coordinating care? Don't you people talk to each other? I keep having to tell the same facts over and over again. I sure wish you would talk to each other. Tell us we're good parents, and let us know that when we leave, you won't forget us. Notice for critical care, it's really quite similar. I do want to call out one piece between the two lists. See that one about be pleasant? Golly, sounds like they're trying to change personalities. But what parents have explained is when your child is so ill, you lose all perspective. And if a person comes into your child's room or into your home and they look serious, you immediately assume it's bad news. And it's more bad news about your child and your situation. So if you come into a room and you know you're down, you know you're serious, just tell us, they'll say, that it's not about us. It's about a different situation. So we know then many things about being a good parent, but I do want to share with you, we don't always use it. So this is a study we did that looked at transcripts from family conferences. This is a study led by Dr. October as well. We looked at those transcripts to find out how many times was there any discourse coming from a clinician to a parent that indicated the parent had really done a nice job. And in less than a third of those conferences was there a positive comment that was made from clinicians that would suggest the parent had done a good job. But we should ask each other, do we hurt parents when we ask about being a good parent? I shared with you that not everyone wants to be in these studies, and I think that matters. We've had refusal rates of 11 to 21%, so this is not for everyone. But I do want you to know that after every one of our studies, we contact participants and ask 3 questions. What was good about being in the study? What was bad or hard about being in the study? And is there anything else you'd like to teach us? Parents are very clear that what was good was the thought that they might be able to help others. They would really like something good to come out of all the bad that they have gone through. They do acknowledge that speaking about what has been hard can be very stopping. You suddenly have a memory of something that was not good, but they don't think it's bad. It's hard. And talking about hard things, according to them, can actually be good. Multiple parents have said to me, why now at end of life do you finally ask me about being a good parent? Where were you earlier in my child's treatment? Had you asked me then, I think I would have made different decisions. I would have had different thoughts. And when you came and asked me to be in the study for the first time, I had to acknowledge that things were not going well. And what is it that's bad or hard about being in a good parent study? Because there are hard things. Almost 90% said really nothing was bad, but it does trigger memories. And see, that last one did not like that questionnaire. That's that research tool that we use that had the 4 options, what's most important, second, third, and fourth. We have retired that tool. It will not ever become a clinical tool. But I do want you to know from a national survey led by Blythe Lord, Megan Weaver, Lori Weiner, Marie Newman, and me, asking parents who are members of the Courageous Parent Network about being a good parent to a very ill child. 80% said, I would have liked to have talked with my clinician about this, but only 6% got to do that. 60% felt the need to talk about this, so they talked with friends and relatives. So what is it then that we are missing from this science that we've got to go after? And I'm going to suggest to you, if we had a theory that framed all of this, I think we would be asking different questions. I think we would be discovering more about parents, about ourselves, and about the interactions between us. Think about it. What is your definition of being a good doctor? What is your definition of being a good nurse? Your definition of being a psychosocial expert? We each have an internal definition that comes to bear in our clinical interactions. But I'm going to go further. I'm going to suggest that if you and I ask that question of each other when there's tension at end of life, because often there is, even in well-functioning teams, I'm going to suggest it's because our definitions are beginning to clash. We could all offer a general definition about being a good whatever, but if we are talking about being a good nurse to this child, a good parent to this same child, and so on, that is where we can make clear if our values can get into alignment or if they are not in alignment. So we don't have a theory, it's a goal, it's a whole, but we do have a beginning model, and I only want to point out a couple of things for you. Notice in the middle, being a good parent to my seriously ill child. On the far left, notice wanting so badly to be on the same page as clinicians. It means a lot. Notice underneath that how much it means when staff convey respect for the parent, but also notice the dotted lines around those. It's because they are so variable. They can change very quickly. And this is when with advocacy, you might see a parent say, I don't want to work with that person anymore. They don't understand what I'm doing. Being doubted by others is very painful, tends to be grandparents and tends to be us as healthcare professionals. But a big one, knowing my child, how very important it is to parents to be believed by us that they do know their child. Notice that there are these little letters, CCA. This is from parents in the PICU who get angry. Parents in oncology with children with incurable cancer rarely get angry, but parents in the PICU, particularly with children who have had a complex chronic condition since birth, and they've been taking care of the child since that time, many times giving up friendships, family, are angry when they feel that we question their knowledge of this child. Notice too, there's another point where there's anger, helping staff to value my child. We never hear that from parents of children with cancer, but we hear that from parents in critical care units whose child has had a complex chronic condition. And parents will say, why do they keep saying to me, you could let this child die? This is my child. So very important aspects that do distinguish certain subgroups of parents and their experience. But may I share with you that parents are trying throughout all of this to be realistic. They want to understand what's happening, but they also want the privilege of hoping that somehow something better might come. So we have tentatively labeled this model, doing my best for my child's possible best. But it's not just theory that's missing. I'm going to say to you, we really don't have many voices other than white, middle class, upper middle class moms. Where are the dads? Where are our families of color? We really need to reach out and do better. It's great that we have these descriptive, qualitative studies and findings. It's good that we have interventional work, but we really need to go beyond surveys, interviews, cross-sectional studies. So for all that we don't know, we do know some things. We do know that parents are very willing, for the most part, to talk about their internal definition of being a good parent to a very ill child. We know it's not static, that it changes, and that we need to be able to cipher when there's been a change and to know which attribute now is most important to the family. We do need to be comforted by the fact that most parents deny being harmed by talking about being a good parent. Acknowledge it can be hard, but it's not bad. And please know how very much parents believe in you, that you have the ability to help them to do their best on behalf of their very ill child. I thank you all for your interest, and I welcome your questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.